And we are live. I've just been talking to myself for the past 5 minutes, not realizing that I hadn't connected my streaming software to YouTube Studio. So I've had a very nice time by myself, talking to myself. And, streaming is not as easy as plug and play. Like, it's actually got a little bit of complexity to it. Anyway, hello again, everyone. Thanks, Codal B, for putting the emojis in. I was just saying how basically I was just eating some fried rice when I found out that actually you could have emojis for members. And I was like, hell yeah. So I just did all these random poses and made the emojis. And then the rest is history. So now members and stuff can, hey, Weeping Scorpion, welcome. Now members like Colonel B, you can use those emojis whenever you like. I should add to that library though. Feel free to send me some. If you get any screen captures, you can fill it out. Hey Naomi. So look guys, another day, another ECG. I want to finish this textbook and I'm at ECG 22 of 200. So we got some work to do. Put it in the background, have some background noise, all good. If you just enjoy the ambiance. What are we doing today? That's about it. What other announcements are there? This is my last day of isolation. So I actually want to do like some solid streams today. And maybe I'll do like a house reaction video later. I've been making less YouTube videos because I don't really enjoy editing. Like editing is not that much fun. Distel Inchen, welcome Distel. Don't think I've seen you in the chat before. You're very, very welcome. Nice to have you here. So yeah, I think I've been preferring streaming because it's way less people watching it, but it's nicer, like tight-knit community, and there's no editing, which I love. Yeah, wonderful, Naomi. Enjoy your studying. Good luck. Stay focused. Keep hustling. All that good stuff. Well, if you're studying, then so shall I. Let's get a sip of water and get cracking. Collectibles for trophy hunting. Mrs. Madame Talbot, everybody. That is my sister. Shout out Alexia Talbot. Alexia, yesterday Mum joined the stream. I feel like my whole family is joining. Everyone say hi to Mrs. Madame Talbot. If you guys want to learn a little bit of French, then definitely check out her channel. She does really good learn how to do French, like learning French for kids videos, but for any age really. I helped her set up that channel. No shame. Hey Casey, welcome. Lovely. I'm gonna get cracking with some ECGs and yeah, feel free to. Actually, I'll go for this. There we go. All right, we've got a 75-year-old man presenting with cough, dyspnea, and wheezing. Okay, cough, dyspnea, and wheezing. Obviously something respiratory is worrying, something cardiac is worrying. Let's check it out. Let's keep it structured. This looks pretty tacky. What's this rate? This is about 3 boxes, so it's approximately 100 beats per minute. So you count the number of big boxes between the R waves and divide by 300. So 300 divided by 3 is 100 approximately. All right, is it rhythm? Is it regular? So yeah, this looks regular. Yeah, it does look pretty regular, doesn't it? And the next thing to look at is there P waves? Okay, so I see P waves. They're a bit strange, aren't they? They're like a bifid P wave because they have these two little spikes. So yeah, some bifid P waves. Bifid P waves. Now, what does that mean? I can't remember. I think it means, yeah, some abnormal atrial issue. So I think it's like, it's not multifocal atrial tachycardia because they're all similar morphology. Oh, I think it means atrial enlargement. That's right, because it's like the atria is so big that they're causing this bifid atrial enlargement. And to tell whether it's right or left, you have to do things that I don't know how to do. Okay, so that's interesting. Let's do the axis. So this is negative in lead 1. It is negative in... Whoa. It's negative in both lead 1 and AVF. That is extreme axis deviation, which you can get in obesity. I think you can get it in COPD. So I think we call that extreme axis deviation. We'll see. I'm not so sure about that. I haven't seen a negative in both before. I'm wigging out. Obviously the main prize here is the QRS, which is wide. So QRSs are either narrow or wide. There is no such thing as a normal QRS. It's narrow or wide. And the QRS here is wide because it's bigger than 3 squares, or it's on the cusp of, it's 4 squares. 4 squares. 3 squares is the cutoff because it's 0.12 milliseconds. Yeah. 0.12 seconds or milliseconds. Anyway, it's very short. It's 12 units. And it's wide. So the morphology, this kind of RSR, is a marrow bundle. It's a right bundle branch block. Right bundle branch block. So right bundle branch block with massive axis deviation. I'm pretty sure that's like a scarbosis thing. That's very worrying. We've got T-wave inversion happening, which is also a sign of ischemia. So I'm worried about ischemia. Worried about ischemia. Yeah. So we've got this sinus. So it's sinus rhythm. It's 100, so it's slightly tachy, maybe a bit quicker. Yeah, maybe 110 or something. It's a right bundle. Yeah. And you've got what's happening with the STs. They're not. Yeah, they're not like out of this world. So not an ST, but definitely probably something happening in the heart, like some ischemia. Maybe it's early, maybe it's like a posterior thing. These notches. Yeah, cool. I'm happy with that. Let's have a look at the answers. Sinus tachycardia, rate is 110. We've got right bundle branch block. I want to see what they say about the axis, because that was confusing. We've got right ventricular hypertrophy. I always miss right ventricular. I just never diagnose it. I think in this one, it's the amplitudes. I don't know. Anyway, right ventricular atrophy, and we've got myocardial infarction. So we've got ischemia. Although many criteria exist for the diagnosis of right ventricular hypertrophy, the most common is a rightward axis. The RS ratio in lead V1 is bigger than 1 and V6 is smaller than 6. I've got to look into diagnosing right ventricular hypertrophy. I don't know how to do that. There's so many different things. In the presence of a right bundle branch block, however, the R wave amplitude in lead 1 must be more than 15 millimeters, as is the case here. Okay. This patient has developed a right ventricular hypertrophy from severe chronic obstructive pulmonary disease. That explains dyspnea and breathing. Q waves are present in the right precordial leads, indicating an old anteroseptal MI. Aha. That was so it's abnormal to have Q waves. You see how in this ECG there's like no Q waves in V1 and V2? These Q waves in V1 and V2. What leads exactly? Q waves are present in the right precordial leads. Yeah, right. So it's 1 and 2, which is abnormal. Okay, so they didn't say anything about the T wave inversion. Anyway, Q waves. Good to know. Abnormal in V1, V2. All right. That was not really a pass, hey? That was a whatever. Better luck next time. That's what that one was. Key learning point here is Q waves are not normal in V1, V2. That's it. Hey Sylvia May. Haven't seen you in the chat before. You're very welcome. Tacky wordplay. Yeah, that's funny. Sorry, I go through the chat between different between the different ECGs because I kind of really enjoy the break. Yeah, nice. Let's keep hunting. 4 answers. Next, ECG. All right. In this ECG, we've got a 43-year-old man with severe palpitations. It's tachy. So let's say, is it regular? Yes, it looks regular. Regular. I don't really. Like, this is a bit of an interesting morphology of a T wave. So obviously there's no P wave here. Is this a P wave in the T wave with a first degree heart block? I don't know. It's regular, so it's weird to have no P waves. Anyway, I'm going to just say Curie first degree heart block. Now, if these are not P waves, that means there's no P wave triggering the depolarization, in which case we're worried about like a AV, like an accelerated rhythm. Because if it's not the sinus node, it's going to be the AV node. But the narrow complexes. Oh no, that's kind of wide. 1, 2, 3, 4. Okay, so there's a wide QRS. So I think this is a junctional tachy. I don't know. Like when you see wide QRS and it's tachy without P waves, obviously ventricular tachycardia is the concern. Especially with the history of severe palpitations. So that's what we're worried about. But it's, yeah. All right, let's see what the answer is. Let's keep looking at the answer. I haven't done all the other stuff. So, okay. Axis. So this is positive. This is basically negative, but kind of unequivocal. So that means that the axis is towards the left axis deviation. We've got the M's, which is a right bundle branch. We don't have the Q waves, which would be pathological. The T waves are inverted, so this, I don't know, when I see T wave inversion, I'm like, okay, there's an abnormality, probably ischemic, not sure exactly what's happening. Let's have a look. So it's a supraventricular tachycardia, which is a bit weird because I thought you would see P waves in a supraventricular tachycardia. So let's read on here what's going on. And we got the right bundle branch block. We were right that it's tachy. I thought it was a little less quick than that, but anyway. All right, we've got a wide complex regular tachycardia without evidence of sinus P waves. So yes, we need to be worried about ventricular tachycardia. However, the treating physician was quickly able to obtain a copy of a previous ECG, which demonstrated sinus rhythm with a pre-existing right bundle branch block. Most importantly, the QRS complex morphologies were identical between the two ECGs. Yes, so there's no change in QRS morphology. So it's SVT with right bundle branch block. So you just give them adenosine for the SVT. I'm going to have to come back to this one later. Let's keep going for now. That one was a little bit confusing. 52-year-old homeless alcoholic man found lying in an alley. Okay, so we don't have a rhythm strip for the whole 10 seconds. So let's just go for, we'll just start at lead 2. Is it regular? No. This distance and this distance is irregular. These look pretty regular. See, this is where you really need a piece of paper. It's impossible to like judge this very accurately. I'm gonna call it. Alright, is there P waves? Let's start there. So these kind of look like bifid P waves. That looks like a P wave. Ugh, there's no much P wave here. Thinking there's some kind of heart block happening now. P wave, P wave, P wave. It's pretty long. It should be 12. So 1, 2, 3. That's 12. So it's a first degree heart block at least. If that's a P wave, that's massive. That's a huge first degree heart block. It actually looks like it's getting longer, but there's no obvious dropped beats, right? No dropped beats to my eye. It's got a right bundle morphology. Okay, so what am I going to say? I'm going to say first degree. What's he got? He's alcoholic. He's found lying in an first degree heart block. What's the rate? The rate is 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14. So it's 60. There's 14, right? So it's 60 plus 4 times 6, 24. So it's 84. 84, so he's not tachy or brady. He's got a right bundle branch block. Right bundle branch block. What's happening on this axis? So that's positive. It's kind of positive, so normal axis. You know, I'm not sure about this right bundle branch block because this hasn't got the inverted appearance of the classical right bundle branch block. So this is probably a J wave, which is like, and if he's found lying in an alley, it's like hypothermia. Obviously, you find that out when you do his body temperature and reheat them. So we think there's first degree heart block. Any other abnormalities? These T waves don't look great. Yeah, there's some T wave inversion. Yeah, abnormal ECG for sure. Let's have a look. So they think it's a junctional rhythm. They say it's a junctional rhythm, prolonged QT. These are tricky ones. I'm not feeling bad about missing this. Accelerated AV junctional rhythm, rate 84. That's what we got. Prolonged QT. Oh, I didn't calculate the QT, and we got J wave suggestive of hypothermia. Okay, that's good. QT. Let's quickly. I've got to be more systematic. I think I'm just skipping steps. So QT is from there to there. Doesn't look that prolonged. So a prolonged QT is like more than 450 milliseconds. One box is 120. No, it's 200 milliseconds. So that's, yeah, it's 4 times 5, so it's 200. So basically 2.5. So if it's 3 boxes, it's too long. Oh, okay, so that's basically 3 boxes. Mum's teasing me about my early live stream. Okay, yeah, so QT prolongation I missed. Which you should think about if someone's possibly ingested drugs, because that can, I mean, this is what can kill you with Torsades de Pointe. The artifact noted in the ECG was caused by shivering. Oh, yeah, of course. Oh my gosh, 25.6 degrees. That is very, very cold. I've never seen anyone that cold and survived. J waves, also known as Osborne waves, are most notable in the precordial leads. Cool. These are positive deflections in the terminal portions of QRS. The exact cause of J waves in hypothermic patients is unknown. Although considered highly sensitive and specific for hypothermia, they can be another thing. J waves are not pathognomonic, so it could be something else. Hypothermia is associated with prolongation of the QRS and QT intervals. Hypothermia is also associated with prolongation of QRS and QT intervals. That makes sense, because the heart is cold, so it's not conducting the electricity as well. So their QT was very long, and the corrected QT is even longer. You always have to correct QT for the rate, and there's heaps of algorithms for that. I just don't know the algorithms off by heart. Other causes for prolonged QT interval include hypokalemia, so electrolyte abnormalities, so calcium, potassium, magnesium. So long QT means you have low electrolytes of calcium, magnesium, and potassium. Could also mean a heart attack. Elevated intracranial pressure. Oh, I remember that from medical school. So sodium channel blockers like TCAs, tricyclic antidepressants. Oh, quinidine, I didn't know about that. And congenital prolonged QT syndrome. That sounds like a horrible disease. QT interval prolongation in hypothermia and hypocalcemia is completely due to the ST segment prolongation. Oh. The T waves remain unchanged. This is not true for other causes of QT prolongation. Okay, so this is all about QT prolongation in this case. Oh gosh, I'm really hunching over. I'm going to bring my desk up. Might make the camera look a bit funky, but it means that my neck won't break. At least that way when I'm hunching over, I don't know. Should I bring this slide up a bit? I'm playing around with my desk setup, as I always am. I'm always messing around with my desk setup. Want to have the perfect desk setup, you know? MKZ, 1 a.m. Gotta go to bed, mate. Hino, just join for the studying. Yeah, it's all good. Oh, you don't need to know what's happening. I don't think anyone watching actually does ECGs besides MKZ, which is pretty funny. Thanks for the comment a while ago, RJH voiceover and audio. I'm sure there's going to be a lot of med students that will appreciate this. Keep up the good work. Yeah, I feel like one day there will be 1 or 2 medical students that'll just enjoy having like a live stream, watching someone go through ECGs and then be wrong about them. I think it's important to be wrong, to show people how often doctors are wrong about things, especially junior doctors, right? And then also show the learning process. Hopefully by the end of this massive textbook, I will not be as wrong as often. That's the goal. That is the goal. Should this go up a little bit? that a bit better? Cool. Guys, we're making great progress. Very happy. We've got, we're up to 25. I think if we go to 35, I'll be happy. What are we up to in the stream in terms of time? 25 minutes. Perfect. Let's keep going. I'll keep the microphone close for the ASMR. 68-year-old man with a history of congestive heart failure complains of dyspnea. Okay, so lots of differentials involving the heart and lungs right now. We're worried about heart attacks. We're worried about pulmonary edema. Let's have a look. So I really like having one strip for the whole thing to judge whether it's regular or irregular. It's really hard to judge if this is regular. It looks irregular. I'm pretty sure this is continuous time so that you can count like these, because that's how you count the heart rate. So let's just call it irregular. P waves. Oh, that's barely a P wave there. P wave, P wave. Different morphology, P wave. It's a different lead. Okay, we got P waves, so it's irregular sinus rhythm. The rate is 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. So it's 66. It's weird to have irregular with sinus rhythm. Mild ST in lead 2, but it's only 1 mil, and you need 2 millimeters for ST elevation to be real in V2 and V3. So not worried about that. The QRS is 1, 2, 3, so it's not too wide. If it is wide, it's borderline. I'm trying to look for the effects here. The T waves are a bit abnormal there and there. Okay, so we've got lateral T wave inversion, lateral leads, T wave inversion. So AVL is normal though. This is a bifid. So low amplitude T waves. I don't know about this one, guys. You guys got any ideas? I've got I mean, the P waves aren't really that early. Like the PR interval's not too long. QRS is not too long. But there's some abnormal T wave stuff. And the kind of lateral leads. And the inferior leads. Alright, let's have a look. This is a rough stream. These have not been going well. Maybe next stream I'll do like introduction to ECG just to go back to basics. Hey Sido, thanks for joining. Okay, so it's sinus rhythm. The rate is 66. Premature atrial complexes. Oh yeah, PACs. I need to learn more about PACs. Left ventricular hypertrophy. I suck at diagnosing that, so that's okay. Previous high lateral MI. Oh, I didn't look for Q waves. Non-specific T wave abnormality in inferior leads. And a digoxin effect. Okay, so we got the T wave right. We got this and this right. We missed the PACs. And let's just quickly look what suggests. I mean, is it this little Q wave? That's pretty small. This is a pretty big Q wave. Let's have a look. The second and seventh QRS complexes occur early in the cycle and are preceded by a subtle P wave. Therefore, these are considered premature atrial contractions. The second and 1, 2, 3, 4, 5, 6, 7th and 7th. Okay. So it's a regular rhythm, but that's why I was confused with the irregular sinus rhythm. So if I see irregular sinus rhythm, think of premature atrial complexes as a differential or ectopics. Q waves present in leads 1 and L occurred to a previous MI, so they shouldn't be there. So in 1, Q wave and AVL. Yeah, this Q wave that I circled before looked pretty big, didn't it? Okay, so that's the pathological Q wave. I didn't do rhythm either. I didn't do axis, but the axis is normal. It's positive. Q wave abnormal. Due to previous MI in the lateral wall of the left ventricle. Wow. When leads 1 and AVL are the only lateral leads involved, it is presumed to involve a high lateral portion of the left ventricle. That's pretty niche. I don't think I'm up to that yet. The ST segment depression / T wave inversions. ST depression. I'm not allowed to miss that. That's pretty subtle. Oh yeah. I guess that's what I was circling. In V5, V6 have an appearance similar to the end of a hockey stick. This hockey stick appearance is often associated with digoxin use, referred to as the digoxin effect. Cool! So this is the hockey stick. Oh, nice. Nice. Okay, so I have to look for this. It will not just show itself to me. So this is the hockey stick. Oh, how exciting. Digoxin effect. Let me make this really pretty. Digoxin effect. It is not necessarily associated with digoxin toxicity, however, so this can be a normal variant. PACs are also common in finding with people who take digoxin. There you go, guys. Very exciting. Hockey stick. Sorry, some of your messages are getting blocked. I have to unblock them manually. It's a little bit random. Okay, guys, let's keep hustling. 85-year-old female reports with recent syncopal episode. Syncope can be many things, but you're worried about an arrhythmia that has caused poor cardiac output and causing a fainting episode or a syncopal event. This is an abnormal ECG. What's the rate? Let's just be structured. Rate, rhythm, axis. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. Okay, 13 beats is 60 plus 30, so it's around 90. Sorry, there's a kookaburra outside. This is very Australian. Sorry. Oh, how many beats was it? Okay, it was around 80. I've forgotten how many beats. Doesn't matter. Is this sinus? No, this is pacemaker. So permanent PPM, permanent pacemaker, not sinus rhythm. There's only one blip, so there's no atrial pacemaker, it's just ventricular. And I remember you have to always look at the capture, so there's a QRS after every blip. Yeah, there's QRS regularly, so that's 100% capture. Okay. Anything else? We've got a left axis deviation, because that's negative, that's positive. Obviously YQRS, that's normal because you got the pacemaker, so it has an abnormal depolarization, and obviously some ST stuff, but that's normal because it's a repolarization, and there's probably, you have to see if there's chest pain presently. Let's have a look. Why do you not... There we go. Oh my gosh, this is getting glitchy. Oop, almost saw the next one. Just not looking, just drawing over it. Good. Okay, we've got ventricular pacemaker, rate is 80, 100% capture, ST segments and T waves are appropriately discordant to the QRS complexes, similar to left bundle branch block. Yes, I still haven't looked into this appropriate discordance business. Something I got to do. Hey, good job. We got one. We got it. Good job. You know, I've got 7 years of training ahead of me, so if I can get on top of this stuff now, we're good. Hello. Hello, hello. What have we got here? This. Okay, so it looks regular. Now, is it sinus? Man. You see, that's a P wave. It's very short P waves. It's very junctional sounding. Like, isn't that the thing? If it's a short PR, you're worried about a junctional tachycardia. I don't know. Anyway, we've got a tachycardia. It's quick. It's 150. So you need to be careful of a flutter here. If it's tachy, the next question you ask is it wide or narrow? It's obviously narrow complex because you can just kind of gauge that. These are all narrow. So narrow tachycardias are all SVTs, superventricular. Can be AF, sinus tachy, or A flutter. To me, this looks like sinus tachy. If it's regular and those are like subtle P waves, that's what I'm putting my money on. And palpitations and lightheadedness, I don't know why she's getting those. You have to treat the underlying cause. Axis is normal. You guys got any ideas? A junctional tachycardia, Paul, is when the sinus node, so in a normal heart, this is my understanding. In a normal heart, you have the sinus node, the atrioventricular node, and the Hypertrophy system. If this doesn't make sense to you, then we probably have to go through the basics, which would take about an hour. So I will do that one day. I'll do the basics, like a full stream on just basic heart anatomy and stuff. But a junctional tachycardia, briefly, is essentially the sinus node is out of action, and it's the AV node sending the impulses. And why do they call it junctional? I guess this is the junction, the AV nodal junction. And normally that's pretty slow, but if it's fast, you call it a tachycardia. I don't really know the main causes of a junctional tachycardia. I think drugs and stuff. Okay, so it's superventricular tachycardia. That's what we said. The rate is a bit quicker than 150, which is a bit quicker than what we said. It's narrow complex tachycardia. Distinction between the three main causes: ST, SVT, atrial flutter. I'm not going to keep reading. The way you distinguish is based on the P waves. Here we've got kind of looks like a first degree. Okay. It's made on the presence and type of atrial activity. In this case, we have retrograde P waves in inferior leads, which is a common finding in SVT. Okay, so just with vagal maneuvers. Yep, so remember SVT, you reverse SVT with vagal maneuvers, which is like a syringe. Blow into a syringe. It doesn't actually say what type of SVT it is. It just says that's how you differentiate it. Oh, sorry, no, it's saying it is SVT. But I feel like supraventricular tachycardia could also be. I've got to really look at my differentials. I don't think that's right. Hi. Alright. We're getting there. This is the grind, team. Hey, Mark. Oh, today's been a pretty rough stream. I feel like they're getting harder and harder, these ECGs. Oh, and I'm not getting better and better. The thing is, though, these are like meant to be challenging ECGs so that when you are on the floor, you can, like, it's a bit easier. I'm okay with getting everything wrong here because I'm basically doing ECGs of someone 2 years ahead of me. So I'm doing this 2 years early because it's when you're actually 3 years ahead of me, because I won't have to do ECGs for another 3 years, sign them off. So before anyone thinks I'm stupid, I'm doing stuff that I should be doing in 3 years' time. But I thought I'd do it now because I've just been live streaming video games this whole time when I'm otherwise well and should be at work. So I thought I would like upskill with ECG interpretation. But if I do a bit of ECG study this morning, guys, I'll probably play some video games this afternoon and do another reaction video. How's your holidays going, Mark? Your kids enjoying the blow-up pool, or has it popped yet? It's gonna pop. They always do. I don't know. Maybe these days blow-up pools are better quality, but when I was a kid, they wouldn't last that long. Hey, Siberian Winter. Welcome, welcome. What's everyone doing today? Or studying? I know a bunch of you are just studying with me in the background, which I absolutely love. I think that's so cool. I'm glad to be like hustling with you. Let me know in the chat what you guys are studying. That'll be fun. And let's do this next ECG. I got a question for you guys though. Should I buy myself nice speakers? At the moment, I've just got these Amazon $20 speakers. I really like listening to music on loudspeaker. I've got good quality headphones. That's why I'm okay with shitty $20 speakers. But I just got paid. I've invested a little bit of the money and saved it. I got a little bit left over. Should I buy? There's the sales on. Should I buy myself some speakers? This is first world problems exponentially compounded. Siberian Winter, what speakers do you use? Yeah, the answer is always yes if you can afford them, for sure. Wow, the Industrial Revolution. Yeah, well, that was a wild time for many a folk. All right, let's do another ECG, team. Only 200 to go. I think what I'm realizing is that I'm missing some basic skills in ECG interpretation, so I should probably do ECGs Made Easy book. I read it when I was a medical student ages ago, but I've probably forgotten heaps. So I'll probably do a stream or two going through that book. It's like 100 pages. And then I'll come back to this. So maybe I'll do the first 50, go to ECGs Made Easy, do that, then come back, and then finish the next 150 freaking upskilled as hell. Man. Let's hustle. Let's do a rate. Okay, is it regular? From my eye, it looks like it could possibly be irregular. But it's hard to tell. I'm just going to think it's regular because there's P waves that are pretty obvious. So probably regular. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. There are 13 on a 10-second rhythm strips. There's 60 seconds in a minute, so you times 13 by 6. That's 60 plus 18, so we're looking at around 78. And it's always very approximate, these numbers. Roughly. The best way to take a rate is by holding the pulse for a minute, which I don't think I've ever done. Because basically, from my point of view, it's like, is someone tachy, is someone very tachy, or is someone normal, or is someone very slow? I don't need to know exact numbers. I just need to know if it's like roughly 30 beats per minute, or if it's roughly 150 beats per minute. The difference between like 154 beats per minute and 148 beats per minute will not change anything in someone's management, so I don't waste time. Oh, Hino, you do some video editing. That's cool. Hey, Hino, if you want to reach out, I need some help with video editing. So send me a message on Discord. There's Discord links in the chat. Yeah, I definitely could get an extra pair of hands with editing. That would be awesome. Do you do it full time? Is it your main? We'll chat on Discord if you have capacity to take on someone else's editing. Cool beans. Let's keep going. So I'm going to focus for this one now. I keep getting distracted. Sorry about that. So we said it's a beat of around, the rate is 78. Is it sinus? This looks sinus to me. So it's sinus rhythm 78. Okay. Rate rhythm axis, positive, positive, normal axis. Normal axis. Morphology of QRSs is normal with good progression, but the T waves are not normal. You should not have inversion here. So we've got some T wave inversion, V2, V3. T wave inversion, V2, 3. Alright, let's look at some intervals. PR looks pretty good. There's no PR depression. QT looks good. No significant QT. Sorry, ST, I meant to say. ST looks good. No obvious abnormalities there. Yikes. I don't think there's much else. Hey, can I ask a question from the chat, actually? What are you guys all subscribed and so you just saw this video on your feed as subscribers, or are any of you not subscribed and just randomly stumbled onto this video? My understanding, the way, because I'm just trying to compare YouTube and Twitch for live streaming, and I feel like YouTube is good for your subscribers to find you live streaming, but with Twitch you might get more people who don't know you just stumbling onto your stream. I don't think they share this video with like randoms. I think they're probably like, I think the YouTube algorithm just shares it with people who are already kind of. Oh, my overlay's not been active. There we go. Yeah, Naomi, you're an OG. OG. Oh, Sohail, so you're not subscribed. So how did you find, like, have you watched other, so Sohail Chabra, have you seen other videos of mine, or did you just randomly stumble onto this stream? Like, I'm trying to work out if YouTube is suggesting this video to my, like, existing audience base, or is it actually suggesting it to other people? Yeah, Hino, so you saw, yeah, cool. Oh, thanks, Ghostly. Okay, here's the big question. Are any of you subscribed from the days where I was called Medico-Sil on YouTube? Because that's real early on. I changed from Medico to Dr. Sil, a while ago. Okay, cool. Thanks, Sohail. That helps a lot. Yeah, so that confirms what I think is the case, which is that YouTube will suggest live streams to your existing audience base, but probably won't have high discoverability. It won't really show live streams to new people, which I'm fine with, because it kind of keeps it. It means that you guys already know me. We have a bit of a relationship. You can chat a bit easier. Oh, Naomi, yeah, your notifications are a bit off. Maybe if you want notifications, make sure you hit all, not just personalized. Yeah, I found Dr. Hope's YouTube channel maybe a week or two ago, and it is eerie. We have we're basically just the same person on different countries. I feel like I'm copying a lot of his stuff. A lot of it, like, I really wanted to do a Die Hard reaction video on Christmas. I didn't get around to it because stuff came up, and then he did one. So, like, we're really on the same page. Like, we want to do very similar content. So I haven't watched many of his videos, but I should try and see how he does them. I think he's similar in that, like, yeah, he's just a very likable reactor, and I think he does the trauma diagnosis stuff, which is what made him viral, which is really good. Now I feel like I can't do that though, because it's his thing. I don't want to just copy, but it would be fun to do that. Yeah, that's right, Paul. Oh, I got distracted again. Okay, come on. All right, all I've got for this one is T-wave inversion. It's a young guy. It might be a bit of like an arrhythmia. It's hard to tell, and yeah, we will see. You can have, as a young person, arrhythmias with sinus rhythm. And they're just called sinus arrhythmias, and they like change with your breathing. And I have that. So like if I take my own pulse, it's irregular, especially when I'm breathing. Okay, that was number 28. Oh. Oh my gosh. Okay, sorry, I was just looking at this figure from... Oh, it's for case 29. Don't look. That's the future. Why would they show you that early? Okay, well there we go. It was an arrhythmia. The rate is 75, and we got something called persistent juvenile T-wave pattern. Never heard of that in my life. Normal children and adolescents have slight posterior orientation to the T-waves, producing inversions in the right precordial leads. So, is that what the right precordial leads? Yep, bang, bang, bang. Cool. All right, we're picking up on the important stuff here. With advancing age, the T-wave orientation becomes more anterior, producing upright T-waves. So T-waves, if you remember, is the repolarization of the ventricles. Oh, Dr. Elliot Carthy, yeah. He's, oh, hang on, I'm going to finish this ECG, then I will talk about Dr. Elliot Carthy, who is like, just, I have followed Dr. Carthy's, I'll just call him Elliot. I have followed Elliot's growth from an early stage, from when he was like maybe 3,000 subscribers. Hang on, let me just finish this ECG. Advancing age. You know what would be a fun stream, guys? Is like going through all the medical YouTubers and doing like an analysis of them with you guys. Because you guys all watch a lot of... I'd love to collab with Elliot. He's so likable. He's so kind. He's so like warm. Anyway, sorry, I'm going to finish this and then let's talk about some ideas. You've just given me a good idea. With advancing T-wave, the blah, 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 normal young adults, blah, 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 T-wave inversions, V1, V3, blah, blah, blah. These T-wave inversions are asymmetric and shallow. If the inversions are symmetric or deep, or if the patient is older, you should be worried about ischemia. Okay, cool. So we're worried about symmetric deep inversions and obviously the age. So this is a young dude. Yeah, 28. Oh no, 30, 35. So not worried about him. Okay, 29. We're making good progress. I'm going to take a little break to talk about some... So Colonel B has sent me a list of almost all the medical YouTubers. So I think I definitely... Oh, what's going on there? My green screen needs to be moved. Is that better? Is that good? Yeah, green screen's better now. So, yeah, I've got a list of a lot of different medical YouTubers. It's a kind of overwhelming list. I don't know how I'm gonna I'll see you, Frost. Yeah, I don't know exactly how I'm gonna reach out to all of them. I think I just gotta go one at a time. Dr. Mike would be awesome. I'd love to join him, and obviously he is ridiculously handsome. Like, it's like, yeah, Gustavo, have a look in the description. That's the textbook's in the description. It's called ECGs for the Emergency Physician. It's not a beginner text, so you need to know a bit about ECGs before you go through it. Oh, that's cool. Brain books. Yeah, okay, guys, you know what? Midlife crisis. All right, guys. Slow down, everyone. I need someone to go through this chat and get all the names of all these YouTubers, and then we'll do a live stream of me just going through all the different YouTubers, doing a bit of an assessment. And no worries, Gustavo. And then we can kind of talk, and then we can like decide together who we should reach out to. That would actually be a pretty fun stream. And then we can like watch some of their videos together, and we can react to other doctors' reaction videos. That would actually be fun. What do you guys reckon? All right. Naomi, you have to study. So can someone else? I think I've got actually probably all of the different names. Like I've got like 20 different YouTubers. So I'll do that stream. I don't know when. By the way, Happy New Year's Eve, everyone. I've been in isolation, so every day is the same. All right, I'm going to stay on task for this stream and keep going on these ECGs, and I will do a stream going through all the different medical YouTubers with you guys, and I'll give you guys a bit of warning so that you guys can be available. I'm really bad with giving warning for streams because I kind of just do them when I feel like them, but you guys are awesome and always ready to hang out. I just love that. Okay, next ECG. Gotta remember to change. Naomi, no one can multitask, Naomi. It's actually proven. You decrease your effectiveness when you multitask. But it is true that women can do it better. All right. 29 is a 41-year-old female, chest pain after cocaine use. Boom! I'm not even looking at the ECG. Vasospasm. Treat it like an MI. Let's go. All right, rate. 1, 2, 3. Oh, very irregular. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. 66. Rated 66. We've got P waves before every T wave, so it's sinus rhythm 66. It's irregular, which is weird because you've got P waves. So maybe it's a sinus arrhythmia. Query sinus arrhythmia. Move on. Don't worry about it. Let's keep going. Abnormal. So yeah, we've got some T-wave inversion V1, V2. We've got axis, which is normal. So normal axis. I was really hoping there'd be ST elevation. Let's get a little bit closer. Mild, not really. Whoa, this is massive QRS amplitude. It's overlapping. I can hardly read the QRSs because they're overlapping. There's this upslanted ST elevation here. Maybe I should do it in purple. So slightly worrying. I mean, the thing is, with cocaine, you get vasospasm. So if you have chest pain after cocaine use, you have to do troponins and repeat ECGs. And if worried, yeah, you could treat it like a heart attack. Bifid, atria stuff. QT, we need to always look at QT. It's only looks like it's 2 boxes, so it's not prolonged. These are big T waves and they're symmetric and pointy, but the QRSs are big as well, so it makes sense. Alright, let's have a look-see. What's this all about? These figures correspond to 30. We're not up to 30. What were we up to? Oh, I don't like how they show you the answers before you're even up there. I'm not looking. Yeah, cool. Sinus rhythm, irregular, query sinus arrhythmia. Oh, how do I undo that? Oh. Sinus arrhythmia, we were right about that. Good hustle, everyone. Rate is 65, left ventricular hypertrophy, which is probably that big QRS amplitude stuff. And then benign early repolarizations, which is probably that ST stuff. So let's go through it. The most notable characteristic of this ECG is the presence of prominent T waves. Yep. These may be an early finding in acute myocardial ischemia, but prominent T waves may be found in other conditions as well. Okay, so yeah, we're worried about the T wave changes because that could suggest ischemia. You also have to think about potassium, pericarditis, ventricular hypertrophy, and benign early repolarization, as well as bundle branch blocks. Oh my gosh. Okay, so T waves are so non-specific. It could be any of those things. Oops. Don't look down. I'll just just read through this. This patient had serial ECGs that showed no change with time, and her workup for cardiac ischemia proved negative. See figure on page 58. Okay. How are we going in this stream? One hour in, and we're up to ECG 30. I think I've slowed down. You guys have gotten me excited. Uh-oh. Oh. Bad situation here, everyone. Okay, well, let's be systematic. This guy's having a STEMI. And probably a posterior one or a lateral one. Anyway, let's be systematic. Honestly, I see this, I go straight to a boss. I don't even like. Yeah. This is diaphoresis means sweating, and there's a rule in medicine. If your patient is sweating, then you should be sweating. I love that rule. It's like, okay, sweating it means like they're in this sympathetic state because something's going very, very wrong. All right, let's do this. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So we got 60. It looks pretty regular, so I'm going to call it regular. There's P waves. So it's sinus rhythm. Gosh, this is a horrible ECG. So we got normal axis, just leading up to it, aren't I? And narrow QT. That's fine, it's not tacky. Look, let's just talk about it. Let's just talk about the elephant in the room. All right, we've got ST depression, V2, V3. So ST depression, V2, V3. So that is, and a little bit of V1 as well, actually, sorry. V1 to V3. So that's really right heart. AVR also has, it's not so bad on AVR. AVL is very bad. V1, V3, AVL. So, okay. Then we got ST elevation. So we have reciprocal changes to these in inferior leads. 2, 3, AVF. So it's an inferior wall MI. It's also V5, V6. So it's an inferior STEMI with reciprocal changes in, so inferior STEMI. Cath lab. Save this guy's life. I'm not even going to keep going. Oh my gosh, I got so worried. I was like, yeah, sinus rhythm, okay, first degree heart block, okay, rate 62, where's the MI? Acute inferior lateral MI. Cool, thank gosh. And then maybe a right ventricular MI. Okay, we've got ST segment elevation present in inferior and lateral leads. Okay, inferior lateral, I said inferior. Yes, there was also the lateral leads. My bad. I should have said inferior lateral to sound smarter. Reciprocal ST changes, depression leads 1, AVL, and V1 to V3. When the magnitude of ST segment elevation in lead 3 exceeds that found in lead 2, right ventricular infarction is likely. Okay, so let's talk about that again. When the magnitude of the ST elevation in lead 3 is bigger than 2, 3 is bigger than 2, right ventricular is likely. I don't understand that. I'll understand it one day though. A more definitive diagnosis of right ventricular MI can be made using right side precordial leads. Yeah, exactly. You've got to do right side precordial leads. ECG 31, which is the next ECG. Oh guys, I've never read a right sided precordial ECG. Although this looks terrible. This all looks bad. This is all very, very bad. This is very, very bad. Okay, everyone's dying today. Man, we were just chilling with heart blocks before. And some bloody sinus arrhythmias. Now everyone's getting STEMIs. It's very stressful right now. Oh yeah, just for the record, inferior STEMI doesn't mean it's less good. It means it's on the inferior aspect of the heart, the bottom of the heart. That's funny. Oh, get the paddles. You wouldn't paddle them yet. Your heart's beating. You get the paddles for someone who is in an arrhythmia, like ventricular tachycardia or ventricular fibrillation. See you, Mark. Thanks for tuning by and coming by. I'll say have a very happy night tonight, New Year's. Stay safe, enjoy your blow up pool, and I wish you a lot of love, man. I'll see ya. We need to zap him. Yeah. Don't zap everyone, you know. You got to choose who you zap. You can't just go around zapping people. All right. I think this will be my last ECG for the stream. I don't know how to interpret right-sided precordial leads, but anyway, I think it means that there's elevation on the other side, like they're essentially inversed. So you should read them upside down, is the way that I interpret this. But let's get going. 57, chest pressure and diaphoresis. Oh, maybe it's the exact same guy. It is. The ECG is identical on the other leads. It's just the precordial leads, where you get like actually it's not the opposite, it's just less amplitude of the changes. Okay, that's weird. I'm just going to look at the answer for this one, but anyway, obviously there's ST stuff, depression V1 V2 and some mild elevation V5 V6, elevation AVF, depression AVL, blah blah blah. Oh my gosh, this is all horrible. Let's just see what they're trying to get us to learn here. Yeah, it's the same patient, thought so. So, same stuff. You know, just to be clear, yeah. Oh man, that's not a very big heart block, is it? That's what they think is a first degree. So it is. It's bigger than one. What is it? 0.2 is the. So it's bigger than 1 square. Which 0.2 is. So with a PR interval, to have a heart block, it needs to be longer than 0.2 seconds. 200 milliseconds. So, acute right ventricle MI is confirmed because there's ST elevation in the lateral right precordial leads, V4, V5, V6. So right side ECG involves placing the precordial leads across the right side of the chest in a mirror image. The limb leads remain in an unchanged position. So it's not the opposite, because the opposite would be a posterior ECG, not a right-sided ECG. Acute right ventricular infarction occurs in approximately 1/3 of patients with acute inferior MI and is associated with increased morbidity and mortality. So this is a very bad situation. In the emergency setting, the diagnosis of right ventricular MI is important because it mandates cautious use of nitrates. Ooh, and other preload reducing agents. Otherwise, profound hypotension may occur. Damn. I'm saying damn because this means that I really do need to understand how to pick up a right ventricular. I was hoping that it was like, oh, an MI is an MI is an MI, everyone goes to cath lab, but no, it's actually really important. Because what we do, if someone comes in with a heart attack and chest pain, we give them some nitrate to open up the blood vessels. But that reduces your preload to your heart, and it reduces it drops your blood pressure. Oh, so you do have to be able to diagnose right ventricular MI. So you need to do right-sided limbs before giving any nitrates. That's rough. That's a horrible situation. Like, yeah, I know, Gustavo. That's rough, hey? Gustavo, what's your background, mate? Are you a medical student? Are you a doctor? I'm about to finish this stream, but I'm going to do all 200, and I'm also going to do ECGs made easy. I'm basically just putting a full live stream of, like, just putting all this ECG live interpretation stuff on YouTube to see if anyone wants to watch it. Oh, anyway, crew, I think that was pretty good. That was pretty good. We got 10 done. 10 ECGs done. Nothing wrong with that. We also had some good ideas for future streams. So yeah, next stream we will we'll go through all the medical channels. I might be streaming later on today, by the way. Thanks, Sato. Yeah, I feel like we're making good progress. Appreciate everyone's help and interest. Oh, I'm feeling like I need a cup of coffee this morning. Are you guys all coffee drinkers? I've started using the French press, but I think I want to go to an espresso machine, because not actually for flavor, but because it's easier cleanup. You just tap into like the coffee bin, and then you can just put the coffee grounds into your garden. All right, Naomi. Well, I'd love for you to be there. So when should I do it? Maybe I'll just do it tomorrow morning, but it's New Year's, so I hope probably no one will be available to watch it. But oh damn, Saito. Yeah, my partner can't drink coffee either. She gets shakes. Yeah, I feel like we got some tea drinkers around here. Ha! Naomi, that's so funny. Whoa. I thought some of you would drink tea, but it looks like everyone in the chat is full on tea. All right, guys. Well, next stream, I'm doing a cup of tea. I'm not doing coffee. I don't want to. I'm going to conform. AVS, aortic valve sclerosis. Is that what that stands for? Oh, we've got finally one coffee drinker. Yes, Saito, you better take care of your heart. That's very nasty stuff. Sorry to hear. Yeah. Stenosis, yeah. Well, you take it easy. Don't overdo it. Crew, thank you so much for having I just love how the chat is getting more and more active. The last one was a killer. Yeah, you're right. Yeah, I will do ECGpedia one day. Yeah, exactly, Saito. Every time I've got stuff that goes wrong for me, I have the same saying that I say to myself. I say, worse things have happened to better people. And then I feel better. I'm like, it's not so bad. That being said, I've had a very fortunate and good life, so I'm a very lucky dude. I'm lucky to have, be able to stream. I'm just really grateful. And to have you wonderful kind of people to hang out with makes me feel really happy. I'm really happy right now. I'm just really grateful that this is working out. Yeah. Bisous à tous, which means love to all. Actually means kisses to all, but we can't kiss obviously because of COVID, and we're kind of not at that point in our relationship, obviously. But it's a nice French expression, bisous à tous, which just means see you all later. And yeah, I like to say it at the end of my streams. All right, see you, team. I'll see you guys in the next stream. I might be streaming later today. We'll see how things go. Bye.